Hi, everyone. Welcome to my first independent Zoom lecture, and I hope I'm getting this right. Today, I'm going to follow up on what I said I would do in class, which is an additional description of how we not only take vital signs, but how we interpret them in the process. In particular, looking at what are compensatory mechanisms at play and how that interpretation involves pattern recognition. So let's go over some basics. If any of you need a little bit of a refresher on taking vital signs, that's posted in the course for you. And for this week, we're just focusing on temperature, heart rate, respiratory rate, blood pressure, and O2 set. Remember, there's IP hours available in the lab, and both Leslie and I are more than willing to take any time that you would find helpful to work with you around your vital signs, both acquisition and interpretation. Today, we're going to limit our discussion to adult patients and interpretation of those 5 vital signs. So some important key principles. First, understanding how the human body works. Our body is designed to maintain homeostasis. Now, sometimes people refer to that feedback loop in terms of a furnace. And in a house, we set our furnace temperature, and as the house temperature cools, the furnace kicks on, it starts working, it brings the temperature back up to where we feel comfortable again, whatever temperature we set it at, and the furnace kicks off again. The human body is much more complex. Think of a greenhouse instead of that regular house. So we have solar panels on the ceiling, we have windows that can open and close, we have fans that come on and off, and our house works through a cascade of events. Let's say instead of a cold day, we're talking about a hot summer day, and we want to cool our house. We start in the morning by a house that has been cooled naturally at night. So we've got a nice cool ambient temperature in the house and everyone is comfortable. As the day progresses, the main floor stays comfortable, but the upstairs starts to get a little warm. If you remember, heat rises. The house will then automatically open the windows. In opening the windows, it's still morning time. The temperature outside is cooler than it is inside, and a little bit of cool air comes in and the temperature comes back down. After a little while, that temperature continues to climb, and the outside temperature is warmer than the inside temperature. At this point, the house now responds by closing those windows, and in addition to closing the windows, closing the curtains or the blinds. We've blocked out some of those heat rays, and we've managed to regulate the temperature with, again, just minimal effort and where it's needed in the upstairs floor. As the day continues to progress, the sun raises higher in the sky, it's warmer outside, the temperature starts to climb not only upstairs but downstairs. Several different things can happen. In the upstairs, fans can come on. They're going to push that warm air down, circulate that cool air upwards, so that the entire house is at a more comfortable ambient temperature. They're also going to, we're also going to find that where there is an opportunity to bring in any kind of cool air, we're going to. As the temperature continues to rise through the rest of the day, it may be that we need some air conditioning to come on. In addition to that fan, so we're not going to turn off that fan, we're going to bring in a little bit of air conditioning, and that's going to happen through the use of power that we've collected through the day in those solar panels. As the day progresses, if that's not enough, we may even kick into some fossil fuels. You see that this is a multi-layered response. It's not simply one feedback loop on-off. And that's what happens with the human body. We don't have one feedback loop. We have a cascade of events that happens over and over and over again. So it's important to understand that the mechanisms in our body that support homeostasis, or our body maintaining a range of comfortable conditions, somewhat like the range of that comfortable temperature in the house, is built to have redundancy. That means when one system fails, let's say the system that closes the window fails, there's another system that is still there to kick on, and that might be the next level of system, which is the ceiling fans that are going to come on. This built-in redundancy is mostly helpful, but there are some conditions where it is not, and that's where the body starts to fail. And we'll talk about that in particular when we do our modules focusing on ECG interpretation and how we respond to changing rhythms. As nurses, it's important to keep in mind that our goal is not to rely on those mechanisms. Those mechanisms are like our fail-safe. That's how our body takes care of itself. They are highly efficient, but they wear out. They tire. And what we want to do is be able to intervene as healthcare providers early, recognize what's going on with that human body, and be able to assist it as much as possible to correct whatever is the underlying cause. It's important to recognize as healthcare providers that we're always looking at change over time. A significant observation may happen in one sitting, but more importantly, we want to compare that observation to previous observations and keep our eye to the future. Pattern recognition is what we're looking at. That's where we are able to look at the change in pattern over time, and we're also able to look at the interrelationship of the different factors, in this case, the interrelationship of those various findings within that significant event. We want to treat vital signs with as much respect or even more as any other diagnostic tool. This is really important. They give us acute insight into how a person is responding and what's going on. Often we're sending patients off for an X-ray, for an ultrasound, for a CT, for an MRI, and we treat the results of those diagnostics, the lab results, the X-ray results, with a great deal of reverence. What's even more important is that we treat those vital signs with that same level of reverence. They tell us about the functioning and in particular, the compensatory responses of that human body, and in particular then, the health status of that human being. Each time we take a vital sign, it's important that we observe the presentation of the patient. Those numbers mean nothing outside of our understanding of everything else that's going on with the patient. What we need to do is watch for a match or a mismatch between the two, and more on this a little bit later. And finally, if vital signs seem off, repeat them. Don't trust them. You can repeat vital signs as often as necessary. If you feel uneasy, if you feel uncertain, if something feels a little bit off to you, start with your vital signs. See what's going on. See if you can determine if there's a significant event here, there's a change in pattern over time, if there is a mismatch with any of those findings, and move forward with your interpretation. Okay, step number one, always remember, vital signs should not be thought of as a primary finding. They don't ever stand alone. Rather, each and every set of vital signs requires interpretation. And we have to analyze what we're finding. And they always have to be considered compensatory to the underlying health condition. So vital signs themselves are not the problem. The vital signs represent to us how the body is responding to what the underlying problem may be. Let's talk about normal ranges, and I know you all know this. Temp, typically 365 to 37.5 oral. That's for an adult. We see changes over time. Older persons, we know, tend to have a little bit of a lower temperature or not develop a fever in the face of infection or sepsis. Infants may develop, and young children may develop a higher fever much more quickly. So the range changes a little bit, but this is sort of the generic usual range. Heart rate, 60 to 90, and I talked about this in class last week. Watch for a change that eventually, as blood pressure standards changed over time, we expect that there may be ultimately a change to expect that the normal heart rate, particularly for 20 to 50-year-olds, will move from our current standard of 60 to 100 to be 50 to 90. We'll watch and see. At this point, what we're going to say is that 50 to 60 is a little bit of the gray zone, particularly for a young person. For an older person, not so much, but particularly between ages 20 and 50. And 90 to 100 is also going to be a little bit of a gray zone. It's important also to remember that we would expect a regular rhythm, but also in young adults we may see that sinus arrhythmia where there's a little bit of a change in rhythm, particularly with deep inspiration. Respiratory rate, we see a range of 12 to 20 per minute, more typically 16 to 20. So a respiratory rate of 12 is quite atypical unless you're looking at a young person or a fit person. Blood pressure, 120 on 80 is the upper limit, 90 on 60 the lower limit. And if you remember, the old upper limit used to be 140 over 90. That's changed over time. You'll still see many older people out in the world who still think 140 over 90 is the norm. What we know is that we now classify 120 over 80 up to 140 over 90 as prehypertension. O2 sat, we're looking ideally at above 95%, but above 90% may be acceptable under certain conditions, and we can talk about that a little bit more as we move through the course. So how do we interpret vital signs? There's a whole bunch of steps here. Let's run through them, and then let's get to some examples, because I think that's where they're going to start to make sense. Number one, and you'll see right near the end, same thing, begin by looking at your patient, you're going to end by looking at your patient. Vital signs are irrelevant outside of that composition of your patient's health condition. So you want to have a really good look at your patient and look again for that match or mismatch between what you're finding and how your patient is presenting. When we take our vital signs, we want to begin by looking at each value within the context of its normal range. We want to identify any finding that's outside of the expected range, and we're going to use a check mark for okay, and high for if it's above normal, so an arrow up, an arrow down for if it's below normal. And you'll see on the next couple of slides that what I've done is put a gold star when I'm keeping something in mind. It may be above normal, it may be below normal, it may be within normal, but I want to keep it in mind because something about it may be a cue. Across the 5 vital signs, so we're going to look at each one individually, and then across all 5, we're going to look at the relationship between the various different vital signs. So number one, what is the relationship between the heart rate and the blood pressure? They are often interrelated. Remember, the respiratory and the cardiovascular system are so closely related that we often see a relationship between the respiratory rate and the heart rate and the blood pressure, and the respiratory rate and the O2 sac. Look to see if there are any abnormal findings where typical patterns of compensation are not seen. And we'll talk about those typical patterns of compensation as we go through our examples. So we want to look to see if there is compensation, and we want to look to see if compensation is not happening. We also want to consider relevant patient characteristics. So things like their age, their medical history, their medications, things like that. We want to look at previous vital sign patterns. So again, today's vital sign, or 2 o'clock this afternoon's vital sign, is relevant in the context of what we found at 12 o'clock today, or at 10 o'clock this morning, or yesterday, or last week. It is pattern over time that we really want to pay attention to, but also this particular finding in this moment today. Again, start and end by looking at your patient. And as we're pulling all of that information together, we make a determination. What is this set of vital signs telling us? So the actual act of taking the vital signs is very straightforward. It's very simple. Patients do it all the time by themselves at home. What patients don't do is this deeply analytical analysis and interpretation of their vital signs. So let's try some examples. Number one, we've got a temp of 39.7, heart rate of 92, respiratory rate of 18, blood pressure of 110 on 74, and a O2 sat of 99%. Hey, wait a second. Let's try that again. Because do you remember I said we never look at vital signs outside of the context of the patient? So here's the situation. We've got a 23-year-old man coming to the ER complaining of a sore throat for a few days. He takes no medications, he has no allergies, he has a past history of repeated sinus infection. He's speaking in full sentences, but he's wincing when he talks. And remember, he's got a sore throat. And so here we go again. Remember, vital signs are always compensatory to the condition. So we need those details to make sense of it. Otherwise, we're just analyzing something in sort of a black hole. Makes no sense. So what do you see with that? 39.7, 92, 18, 110 on 74, 99. Take a pause for a second if you want to. Draw your arrows up and down. And let's see if we got the same result. Are you ready? 39.7, clearly a fever, and a fairly high fever for an adult. 92. Now remember, 92 is within that normal range of 60 to 100, but he's a young man, 23. So I'm putting a little bit of a yellow star under that because that might be just a little tachycardic again. We're thinking 50 to 90 for a younger person, potentially, still acceptable. But we're putting the yellow star. Respiratory rate, acceptable, 18. Blood pressure, perfectly fine, 110 on 74. O2 sat, 99%. What are we thinking? It looks like a picture of someone who has an uncomplicated fever. 39.7. He's got some symptoms. The doctor's going to make a diagnosis. Remember, it's important that nurses do an interpretation. We may uncover a situation. We may describe a situation. We don't make a medical diagnosis. So we're not going to move into that, but we have some thinking about this and what this would look like in the absence of other information that we have yet to uncover is an uncomplicated, fairly high fever probably related to his symptoms of a sore throat, and we'd want to do some further investigation to look at that. There you go. So how do these findings relate to each other? Fever, and remember we talked about this before, typically can cause our heart rate to increase. Now, why does that happen? Our body wants to, so first of all, let's start with fever. Fever by itself is compensatory. When we are invaded by some kind of organism that is foreign to our body, that is a threat to our body responds by increasing the temperature because that makes a hostile environment. Typically, that makes a hostile environment so that the bacteria or the virus most of the time cannot survive or cannot survive well. So it is somewhat compensatory, but it is uncomfortable, and depending on how high that fever is, it may cause its own problem, which is why typically we treat a fever because we feel so unwell. So the fever itself is compensatory, but as we get a fever, then our body tries to bring that temperature down. It's that regulating temperature, the way our house regulates the temperature, and it does that. Our heart rate increases as we try to perfuse, open up the blood flow into our capillaries. Our skin becomes flushed as we try to radiate off some of that heat. And so when we talk about his heart rate being a little bit high, it may be related to that high fever. He's a young man, so he's probably compensating very well. We see sometimes an increase in respiratory rate, and again, we do that so that we can take big breaths and blow off that air. He has a respiratory rate of 18. We don't know what his normal respiratory rate is, so that might be up a little bit, or he may just be compensating very well. We have a blood pressure of 110 on 74. In the face of a normal fever, we typically might see a tachycardia, so a high heart rate, but until we are in an extreme situation, well above 100 and something else happening, it would be a long time before we would see a further drop in blood pressure. That would be a sign that something more catastrophic is happening. So when we're looking at the interrelationship between those factors, we see a pattern where we have a high temperature, likely reflected in a probably higher than normal heart rate, but within this case, young male, he's coping well with that. We may see a higher than normal respiratory rate again, though this still is falling within normal range. Everything else is normal. When we were to say what kind of symptoms or signs would indicate compensation is failing, we would look for a blood pressure that is dropping. We would look for an O2 sat that may be dropping. We may look for a further accentuation of some of those compensatory mechanisms. So respiratory rate that moves above normal and a heart rate that moves well above the normal range. What health teaching might be relevant in this situation? Because that's always important for us to understand. We'd look at pyrexia, how we would help the patient understand when and how you treat a fever, what signs to watch for. So we're not only suggesting that perhaps he might take some Tylenol or Advil or some other antipyretic, but also that he might increase his fluid intake to keep well hydrated. This process of increased heart rate and dilation of capillaries and blowing off all that hot air is going to make him at greater risk for dehydration. So we'll keep him well hydrated. That's also going to help to bring his fever down. We're going to ask him to take care of himself, monitor himself, and probably follow up with some rest. Beyond that, the medical diagnosis is something that it requires further health teaching, and I'm not getting into that. I'm just talking about some health teaching in relation to these vital signs. Example number 2, Eugene. Here we've got a 62-year-old gentleman. He's 12 hours post-op after bilateral inguinal hernia repair, and this was a fairly lengthy surgery. Eugene is an elderly gentleman, and so he's actually going to be admitted overnight to the hospital. He has no medication allergies. He takes Questran daily for high cholesterol, and here are the vital signs that you take. Temp is 36.5, heart rate is 110, respiratory rate is 18, blood pressure is 100 over 60, O2 sat on 2 liters is 96%. Take a second, pause if you want, and do your up and down arrows. Remember, up arrow if it's too high, down arrow if it's too low, check mark if it's okay, and our little star if we're keeping it in mind, even if it's falling within the normal range, if we're keeping it in mind. Ready? Okay, let's interpret our finding. 36.5, temp, I'm okay. Are you guys okay with that? Heart rate 110. Well, regardless of whether we're using the new standard or the old standard, we're still above normal, 110. Remember, Eugene is 62. He's got a maximum heart rate of 100. We're seeing 110, so that's too high. The respiratory rate is 18, a little bit towards the higher end of the scale, but he's okay. Blood pressure is 100 over 60. Now it's okay, it falls within a normal range, but I'm going to put a little star. Eugene is 62, he's got a history of high cholesterol. He doesn't take anything for blood pressure, but 100 over 60, what do you think about that as a normal blood pressure for a gentleman who's 62 years old? Even though it's within the normal range, I'm going to put a little asterisk there because I'm unsure. That seems to me questionable, and I want to pay attention to it. His O2 sat on 2 liters is fine, it's 96%. So what kind of pattern are we seeing here? We're seeing a pattern with a tachycardia, so a heart rate of 110, and a blood pressure that seems to me to be on the low side. I would repeat that to make sure I've got the right blood pressure. What other steps might you take? Really important that we see what this pattern is over time. So what's his previous blood pressure? What was his blood pressure in the OR? Have we had vital signs post-op? We should have a lot of them. We should be able to see a pattern within those vital signs, and that should give us some information. We also need to look at our patient. Remember, begin and end by looking at your patient. So we're looking at our patient, and that gives us a lot of information. He's lying in bed. He looks uncomfortable. He is a little bit lethargic. Now, what do we know about his condition otherwise? Remember I told you he was in the OR? One of the things that nurses do really well on surgery is we pay close attention to fluid status. Fluid status is really critical in understanding where a patient may find themselves within this 12-hour period post-op and well beyond that. So understanding how far ahead or behind someone may be from the fluid they got in the OR, and understanding that a very, very significant amount of third spacing can happen. So the patient may have received a lot of fluid in the OR. Often we're worried that the patient will go into fluid overload, and actually that fluid is third space. We're waiting for it to come back. And intravascularly, within the vascular system, a patient is dehydrated. So one working hypothesis here that I would want to confirm a little bit further is that the patient may be dry. He may actually be dehydrated. Do you see how that pattern might fit that hypothesis? He's a little bit tachycardic, his blood pressure is a little bit low. He's had surgery, and it's quite a significant risk that he might be dehydrated following surgery. The other hypothesis, and tell me what you think about this. This man has had surgery. What else do we pay attention to? Yep, we pay attention to infection. Fever is good. Now, fever doesn't always accompany infection, but it's early. 12 hours is fairly early for post-op infection. We usually are thinking 24 hours. So I'm not necessarily, I'm going to keep that looming around, but I'm not necessarily jumping on that bandwagon. But another area to pay attention to is pain. This man is 12 hours post-op, surgery is painful. What kinds of things can happen in terms of a compensatory response to pain? Our heart rate goes up, and our blood pressure may even come down a little bit. Sometimes we see heart rate go up and blood pressure go up, so we're going to have to watch that. But my first question would be to say, how is he feeling? I'm going to look at his tongue. I'm going to look at other things that tell me a little bit about his fluid status. I'm going to look at his urine output. Critical indicator. Now, this man has had bilateral inguinal repair. He may or may not have a Foley catheter. You know me and my aversion to Foley catheters, so I hope he doesn't. Regardless, we'll have done in and out, so we know how much he's voiding. We're going to look at both the quantity and also the quality of that, so the description of how dilute or concentrated that urine looks. We're also going to ask him about his pain. In asking about his pain, he tells us he's actually very comfortable. We look at his urine output. His urine output does not meet the threshold of 30 mils an hour. What does that tell us? We're probably concerned about hydration, in which case we're going to seek a consultation. We'll use our SR communication. We're going to provide the doctor with the vital sign findings, urine in and out findings, and some suggestion about what may be the condition of our patient, and see if we can get some treatment started from likely increasing fluid infusion, probably a bolus followed by a higher IV rate. We're also going to make sure, and we'll talk about this in our fluid and electrolyte class, that he's getting the right kind of fluid by intravenous. Okay, example number 3. Angelica is an 18-year-old woman. She presents at the outpost nursing station on her Northern Ontario community. with complaints of what she calls stomach flu, and she's incredibly tired for the past few days. She's unable to really provide complete details of her medical history because she's just vomiting persistently. But you can ascertain that she's got an allergy to penicillin and that she doesn't know when her last period started, and that her symptoms started after a night of what she calls pretty heavy partying. Here are her vital signs. Temp 36, respiratory rate temp 36, heart rate 136, respiratory rate 26 and labored, blood pressure 90/60, O2 sat 93%. Pause if you want, take a second, do your up and down arrows, your check marks, and your gold stars, and let's see where we end up in just a second. Okay, did you get the same thing as me? 36. It's a little bit low, but I'm going to put a star there. Now, the reason I'm putting a star there is somebody has just come in from outside. Depending on the way we take a temperature, in particular, if we take a tympanic temperature, if we take a temperature using one of those skin thermometers that takes temperature based on the temporal artery, we are likely to get an error in temperature. 1 out of 5 fevers is missed at triage, even in a large urban emergency department based on thousands of patient assessments. So it's important to recognize 36 may be a little bit below normal, but probably it's within a range that I would find likely acceptable given everything else. So what I'm going to do is put an arrow down and a little star that says, yes, it's down, but I'm just not sure that that's something I pay attention to or not. I'll keep a star there. Heart rate 136. Well, I don't need a star there. That is well above normal, and it is concerning. It's quite concerning. Heart rate of 136 is quite concerning. When we're thinking about compensatory mechanisms, a heart rate between 100 and 150 is the highest range you're going to see for regular compensation. Beyond 150, you're looking at an abnormal heart rhythm. So 100 to 150 is the greatest range you can see for compensation. 136 is pretty high, so she is really quite tachycardic. Respiratory rate of 26, again, quite an advanced respiratory rate, and it's labored, very deep, heavy respirations. That tells me that there's something to be concerned about with the respiratory response here. Blood pressure 90/60. Now, here's what I'm going to say. Normal, at the very bottom of the normal range, but I'm putting a yellow star there because I'm not sure what her blood pressure normally is, if this is a compensatory process that I'm seeing, if compensation is failing that I'm seeing. I'm just not sure. So I'm putting a star there. It's something to be concerned about or keep on my radar. O2 sat of 93%, it's okay, but I'm going to say she's breathing at a rate of 26. So she's breathing quickly. Breathing quickly in those very deep respirations is giving her as much oxygen as she can take in. So it's important to keep in mind this idea of work of breathing. How much effort is she putting into her breathing process to be able to get that O2 sat of 93%? It's adequate. I'm not yet going to put a star there, but I don't let go of anything. I keep it all in mind. So what's the pattern that we're seeing here? I'm somewhat okay. I'm not thinking it's a sepsis process. I'm not thinking. She's given us some clues. He says it happened after a night of partying. This is a couple days later. Could we see an impact from this? A couple days later, I'm going to keep it in mind. I always have a working hypothesis. I'm going to keep in mind that she talks about there was potentially some substance abuse a couple days ago, but she says nothing since then. Likelihood is fairly low. If we were going to see something from party drugs, we often see that right away. And if we're looking for that response where we're going to have a high fever, serotonin syndrome, high fever, very extreme tachycardia, tachypnea, that would happen typically in the moment, so in that night of partying. She also tells us she doesn't know when her last menstrual period was. We ask her that because she's a woman of childbearing years. She's got vomiting. We look at her vital signs. The potential that this could, vomiting, which causes a responsive tachycardia, could be part of it, but the tachycardia is so extreme. Now, again, in our last situation, we had a gentleman who was dehydrated, and in his dehydration, he had a tachycardia, and that might be part of it. Could she be vomiting so much that she's dehydrated? It's possible. For sure, it's possible. Could she be vomiting because she's pregnant and she's got lots of things? It's going to be in the sector, in the sphere of our hypotheses. And so one of the things that I'm probably going to do is a urine pregnancy test just to determine if that's something I need to be concerned for or not, regardless of what else I find. I'm also going to say I don't know if there's anything else going on. We've got a new onset of vomiting for a couple of days. We've got increased respiratory rate. We've got a really labored respiration. That's something that's triggering. What is this pattern? How have I recognized this? Where have I seen this before? And how does it fit with the context of this young one? This is a First Nations woman who's living on a reservation. What do we know about the epidemiology of type 1 diabetes? That we know that if there's a higher than normal across the regular population representation of persons with diabetes, what might I think in terms of the relationship between new onset type 1 diabetes and these vital signs? This may represent for me a classic picture of diabetic ketoacidosis. So a new onset of type 1 diabetes where blood sugar is rising so high that my body is responding to it by increasing the amount of urine output to such a degree that I'm actually dehydrated, that I become ketoacidotic from that chemical process within my body. And as I become acidotic, I am breathing these very deep labored respirations at a rapid rate in order to try to manage that acidosis. And I may become hypotensive through this process. Now that hypothesis may be gaining some traction for me because a lot of my vital signs can be accounted for this way. How would I confirm it? What's the very first thing I could do to confirm that? Very simple test would be a finger stick AccuCheck. What if I did that and her blood sugar was 49? Important first step. I have a lot of other things to do. There may be multiple things going on in this situation, but for sure, some important elements cross over them all. I've got a high heart rate and that labored breathing. She's got enough oxygen, but I'm going to watch for the work of breathing to see if she's getting tired. She certainly is dehydrated, and so she's going to require some fluid replacement. She certainly is requiring some kind of treatment for this high blood sugar, and we move forward. If she were to have a positive pregnancy test, would that change the treatment if it's a new onset type 1 diabetes, if she is in diabetic ketoacidosis? No. Treat the mom, treat the baby. It's really critical that we bring her blood sugar down, that we move her away from this diabetic ketoacidosis, and that we manage that situation. She's going to require IV fluid replacement, likely a bolus followed by a rapid administration of normal saline and some intravenous insulin. Pretty exciting. Last example. Here we have Alfonso. Alfonso's an 82-year-old man residing in your nursing home. And he's got a history of mild dementia. He's lived there for about 2 years. Mild dementia hasn't particularly progressed. He's on medicine for type 2 diabetes and hypothyroidism. So he takes glyburide, L-thyroxine, and Aricept for his dementia. Alfonso is a very charming gentleman who makes the rounds in the afternoon. And you notice on your evening shift that he's not wandering the hall, visiting the other patient and doing those rounds that he usually does. So you decide to go in and check on him. And when you go into his room, you find him lying in bed with the blankets up over his head. And Alfonso, as you walk in and begin to move the blankets back, tells you, please don't. My head is killing me. And he needs the blankets there because the sun is blinding me today. And here are his vital signs. Temp 36.5, heart rate 56, respiratory rate 24, blood pressure 170 on 96, O2 sat 96%. Take a minute, pause if you need to, and on we go. I'm going to catch you on the next slide and we'll see what you think. Did you get the same results as me? Temp. Okay, 36.5. I can live with it. You can live with it. Heart rate 56. Now remember, we've talked a little bit about this. 60 to 100 is normal. 50 to 90 may be normal for a young adult male. But for Alfonso, for sure, he falls within the range. So 56 is low. He's a little bit bradycardic. Already I'm thinking, is he on medications? Is there something going on to make it lower? Often older people may be on a beta blocker that will bring down their heart rate, but we know Alfonso is not. Respiratory rate 24, without question, that's an elevated respiratory rate. He's not active, he's not been up walking around exertionally, accounting for that elevated respiratory rate. He's lying in bed, he's got an elevated respiratory rate. His blood pressure is 170 on 96. Again, we're going to think about the blood pressure itself. It's a above normal for sure. Remember, upper elements in terms of normal are 120/80, up to 140/90, maybe pre-hypertensive, for sure 170/96 is hypertensive. In terms of Alfonso's history, is he on medications for hypertension, something that would account for a long-standing history of hypertension? Nope, absolutely not. O2 sat 96%, so that one's fine. So we've got this pattern, again, that we're starting to look at. A low heart rate, an elevated respiratory rate, and a significantly elevated blood pressure. We also have some details from Alfonso. Terrible headache, that's what he says, a headache that's killing me, and light that is blinding him. What am I thinking? Neurological. Immediately, my head goes to neurological. Now, again, I'm not making a medical diagnosis, but I'm trying to put the pattern together because I'm going to need to provide the story through my SBAR communication that's going to make sense. And in neurological conditions, often what we're watching for is an increase in intracranial pressure. And the classic representation of increase in intracranial pressure is as that blood pressure goes up, that heart rate goes down. So it's like a seesaw. Blood pressure up, heart rate goes down. That's that increase in intracranial pressure. And that's really critical. For Alfonso, we're going to have to contact the physician. We're going to have to make a recommendation that someone assess him immediately. In the meantime, what can we do? We can put him in the most appropriate position, which is reverse Trendelenburg. That's head up 30 degrees. We keep the hips from being flexed. What we want is fluid to be able to flow down most effectively, so we don't have our hips flexed. We don't have our body sitting up, but rather it's in that reverse Trendelenburg position. We want to keep his volume status staying the same. So equal in and out. We don't want to give him any extra fluid at this point because he's got a high blood pressure. We want to be careful. Sometimes people with a high blood pressure are prone to thinking we need to bring that blood pressure down right away. If this patient is having a cerebral bleed or something else is happening within their head that's affecting their intracranial pressure, we need to be very cautious that we don't lower that blood pressure too quickly. It will exacerbate a neurological problem most often. It can result in a stroke if there's not already a stroke. It can result in increased bleeding. So we're going to watch that, and what we're going to ask for is an immediate assessment. Alfonso needs to be transferred to an emergency department. Unless he's a DNR, he needs to be transferred. And even if he is a DNR, he's uncomfortable, so we need to see how we could make him most comfortable. But he needs to be assessed right away, and in the meantime, we need to put him in the proper position and have him prepared as much as possible for that first triage. Well, that was pretty exciting. 4 very different patients, all of whom provide us with an opportunity to really understand what it's like to take someone's vital signs, but more importantly, to analyze it, to interpret those vital signs, to look for the pattern, to hypothesize what might be going on, to find the information that confirms or denies that. Closing thoughts here for you. Vital signs are diagnostic. They are equivalent to any other invasive tool. They're more readily available. We can get them in a flash. They give us insight in the moment to what is exactly happening with that patient right now. It's like doing a scan, a different kind of scan. Treat them with the respect that they deserve. It's so critical. We can never, never, never take vital signs without interpreting them. This idea that someone else can take your vital signs is a fallacy. It is dangerous. We all take our own vital signs because over and over through this lecture, what we've talked about is that vital signs are always contextualized by the patient's presenting condition. So when we're doing our analysis, we're looking at the patient. The frequency of vital sign acquisition is determined interdependently by the RN or the RPN and the medical orders. So the medical orders may say vital signs every 4 hours or 8 hours or Q shift or Q day or however they say it. But what that really means is at least. When it says vital signs Q4H, that doesn't mean do them only Q4H. Every time you read that order, you say to yourself, that means I do them at least every 4 hours. It never means don't do them more often than that. It never precludes more often assessment. A vigilant RN is assessing her patient as often as is required. That's why we're there, eyes and hands on our patient. Vital sign interpretation has to take into account patient context, our own observation of the patient, our interpretation of the relevant information, and watching for changes over time. And pattern recognition, an important skill that nurses build over a career is a high-level skill, and it saves lives every single day. You will be involved in saving lives through this observation and through the analysis that you do. Well, that was an exciting half hour. I hope you had a good time too. See you later.